This is going to be topic 41.8, head, face, neck, and spine trauma, traumatic brain injury.
And key concepts. Upon completion of this chapter, you'll understand the epidemiology of traumatic brain injury, classifications of traumatic brain injury, pathophysiology of increased intracranial pressure, the types of herniation syndromes, examination of the patient with suspected head injury, and treatment of a suspected increased intracranial pressure. Traumatic brain injury defined. It's a traumatic insult to the brain. Produces changes in the patient's intellectual, emotional, social, and vocational abilities, or their abilities to do things. Wide-ranging and devastating implications. Immediate implications may include the loss of short-term memory and development of seizure disorder. In the long-term implications, it may include Alzheimer's disease or Parkinson's. A variety of traumatic causes. Leading causes of this is going to be a vehicle collision, and the most deadly cause is the use of a firearm. Peak incidence of ages 15 to 24, and of that age group, the primary result of a head injury is from motor vehicle collisions and assaults. Chief concern. The brain is the most important organ. It's who and what we are. Sources of consciousness, ability to sense and perceive, metabolic substrates. Interruption can impair brain function. And when we talk about this, we talk about things like hypoxia, low blood sugar, hypoglycemia, or hypoperfusion from low blood pressure. Cerebral perfusion is most affected by the traumatic brain injury, and that's because the pressure that increases in there. We'll talk about intracranial pressure here in just a little while, but the pressure that increases in there competes with the body's ability to oxygenate the tissues. Soft tissue injury, brain injuries, primary brain damage that occurs at the time of the trauma. So this would be the first damage that actually occurs. Soft tissue involves gray and white matter. Vascular results in intracranial hemorrhage. Secondary damage is secondary to extracranial etiology that impairs brain function. Concussion. The brain tissue violently strikes against one another inside the head. Signs and symptoms of a concussion include loss of consciousness, repetition of questions, or whenever we see people that are concussed, they continually ask us, what happened? 5 minutes will go by, so they're having a hard time with short-term memory. Headache, vacant stare, and delayed responses. Diffuse axonal injury results from rapid acceleration and deceleration of the brain, and this is within the skull. The shearing forces disrupts the neuronal connections that occur in the brain. And then secondary impact syndrome. Second concussion immediately following the initial concussion within days or weeks. Intracerebral hemorrhage is bleeding within the brain soft tissues. Relatively uncommon and usually occurs due to a rupture of an aneurysm that the patient already had, or an arteriovenous malformation, or alternatively from bleeding within a tumor. It includes cerebral contusion, which is a brain bruise, results from acceleration-deceleration injuries, causes the brain to strike the inner surface of the skull, resulting in a coup injury. So the coup injury, just so that everyone's aware of this is the inside of the skull, and this would be the brain tissue. This is coup, striking initially. Often the brain rebounds off of this, which means it's going to kind of go back the other way, causing the opposite brain surface to strike the inner surface of the skull, and this is contre-coup. So brain inside of there, so then after the initial impact, first impact coup, contre-coup would be an injury here. Cerebral laceration. Soft tissue becomes torn and lacerated, results from penetrating projectiles. An example of this would be a gunshot wound, or bony fragments from the skull from a skull fracture. Extracerebral hemorrhage, bleeding outside the cerebral cortex, below the cranium, which is the bony surface. Injury to the blood vessels inside the meninges. And meninges are 3 layers of tissue: the dura, the arachnoid, and the pia mater, and surrounding the cerebral cortex. It includes traumatic subarachnoid hemorrhage, and traumatic subarachnoid hemorrhage is extracerebral hemorrhage of the small corticomeningeal blood vessels within the arachnoid space. So this is just below the arachnoid space, subarachnoid. Subdural hematoma. Subdural hematoma is from fragile veins that tear and cause bleeding within the subdural space and result in an organized clot that exerts downward pressure on an already damaged cerebral cortex, and this causes intracranial pressure. Shaken baby syndrome, combination of a subdural hematoma and a diffuse axonal injury. This occurs during an infant assault or violently shaking to and fro. So the axonal injury would be shearing force, and the subdural in addition to that. Epidural hematoma results from an intracranial bleed above the dura mater. Typically occurs secondary to a focused blow from an object, such as a club, a bat, something along those lines. Pathophysiology of traumatic brain injury. The skull or the cranial vault's rigid container holds about 1,200 to 1,500 milliliters of volume. Now, 80% of this is from nervous tissue, 12% of this is from cranial blood, and 8% of this is from cerebrospinal fluid. If any one of these increases its volume, so let's say that the nervous tissue got struck and it increases its size because it's swelling, then it's going to displace the rest of the two, very simply. Now, this is a Monroe-Kelly doctrine as a part of the volume-pressure relationship. An increase in one volume must therefore result in a corresponding decrease in another. This is in your book. It essentially works out to the more swelling that we have, the less perfusion we would have, or the less ability of bringing in blood to perfuse the brain we would have. Herniation syndromes. Kind of a mass effect. Whenever pressure builds up in one compartment, that compartment compresses the other compartments. Intracranial pressure increases, mass effect gets greater, brain moves towards the foramen magnum, which is a hole in the bottom. So as we get diffuse pressure running out across cranium, let's say this is the brain right here, as we get diffuse pressure kind of pressing down from this extra cellular thing, whether it be a hematoma or it be a pool of blood. The only hole that is in your cranium is at the bottom. So this is a very sensitive area, which is your brainstem. If you herniate your brainstem, most physiological functions will stop. So herniation syndromes continued. We have 2 forms of it. Let's break them up into 2 categories. We have a supratentorial herniation and then an infratentorial herniation. So this right here is the tentorium. Anything occurring here would be an infratentorial. Anything occurring here would be supratentorial. Now, in these, we have all of these different kinds. I'm talking about this area here, different kinds of herniation. So, supratentorial herniation is number 2. Let's just kind of look at that for a second. So, central herniation, increased intracranial pressure exerts a force upon the dicephalon at the midline of the brain, or midline of the brain above the brainstem, the thalamus, the hypothalamus, as well as the temporal lobes. So number 2 here, pressure would start here and kind of work its way down. This is probably from extraneous pressure from other areas of the brain. An uncal herniation. 1. Lateral forces created by expanding space occupy a lesion created by a blood clot. Compresses the brain at the opposite side of the hemisphere. So number 1 is our uncal herniation. It's this right here. When the little gyri essentially flips over and becomes herniated. Number 3, cingulated herniation. Accumulation of blood from expanding hematoma, particularly at the frontal lobe, creates a mass effect that pushes the cerebral cortex at the medial brain, called the cingulated gyrus, under the follicus cerebri at the midbrain. Now, number 3, we get a movement of this tissue here over this way, causing damage primarily to this from the movement. This right here would definitely cause that. Infratentorial herniation syndromes. Tonsillar herniation, results of expanding hematoma formation proximal to the cerebellum, so above the cerebellum. Number 6, and then we get kind of a unified movement of the tissue downward towards the foramen magnum. And then 4, transclavarial herniation, my apologies. Herniation of the brain through an open fracture, and this would occur here. Say they had an open brain fracture, and parts and pieces of the brain actually came out. All kinds of herniation syndromes types. All of them are devastating, depending on the section of tissue of the brain that we're actually working in. So, history. Compile a complete sample history, signs and symptoms, headache, neck pain, etc., allergies, any kind of medication allergies, medications, comprehensive medication list, past history, complete past medical history, last oral intake, and this is very important for intubation, or in case we need to intubate the patient. Events leading to the emergency, if they have difficulty remembering the events, sometimes, that precede the trauma. This may suggest amnesia, if they can't remember anything, and may indicate frontal brain injury as well. Examination, mechanism of injury, nature of the call. So, like, was it a fall? Was it a cause from blunt force trauma? Injuries that may manifest over hours, as far as the paramedic focus goes. Signs of injury within minutes of the trauma, and the risk factors for secondary injury. 3 major etiologies of secondary injury include hypoxia, hypercarbia, and hypoperfusion. So we're going to be sure that we're supportive of their vital signs. Keep them oxygenated, keep their CO2 levels down, and keep them their blood pressure adequate. Primary assessment, we come up and do a consciousness and interaction level, and we do an ABPU, alert, voice, pain, or unresponsive. As far as coma levels go, initial stage, patient with increasing intracranial pressure may present with decorticate posturing. So decorticate posturing, body, arms, is the arms and legs moving towards the core. Or flexion, they're going to flex. The next stage, the patient may demonstrate decerebrate rigidity or extensor posturing, and this would be they fully extended out their extremities, so their arms and legs would be moving away from the body. The deepest level, the patient may not have any reflexes whatsoever, or may be areflexive. Disability, neurological signs. Well, let's talk about patent airway here for just a little bit. We have respiratory patterns that we often see in head injuries. So we have 3 here that we're going to talk about, or maybe 4, my apologies. Patent airway is primary objective. Respiratory pattern. A normal respiratory pattern for a patient is called eupnea. After that, we see them in stages. So the first stage we're going to see is going to be Cheyne-Stokes respirations, periods of hyperpnea, followed by periods of apnea. Kind of looks like this. So Cheyne-Stokes, hyperventilation, and then we have central neurogenic hyperventilation, which is essentially we're going to run it till the wheels fall off. and then apneustic pattern. And this is pretty profound bradyapnea. And then periods of apnea along with this and the apneustic pattern. And then ataxic. Ataxic or Biot's respirations. Irregular gasping breathing. So this may be like guppy breathing. So as the patient breathes in, there's no pattern to it. It's irregular. We've termed this guppy breathing. Their respirations are ineffective and they're kind of gasping. So those are the patterns. This is the first one we're going to see. This is whenever we switch over to the hypoxic drive from pressure on the brainstem. Oxygen levels increase during this tachypnea phase or hyperpnea phase, and then during the apnea phases of this, O2 levels go down. So most normally we run off of CO2, but in the Cheyne-Stokes they've got so much pressure on the stem that they've switched. Central neurogenic hyperventilation, there's no feedback triggering to this whatsoever. So this is essentially, let's just try to get oxygenated, breathing as much as we possibly can. So there's no balance to this. This is going to run until the wheels fall off or we see another pattern like the apneustic. So respirations are slowing down. They're less than 12 per minute with periods of apnea in between. And then the ataxic would be they're gasping. So this would be the last one on our list. This should be a progression. I want everyone to take note that we could go directly to Biot's or ataxic respirations depending on the severity of the injury to the brain. Alright, and then disability as far as neurological status. Short-term memory. I usually have them remember something and then ask them if they can remember it within a few moments, just to test their short-term memory. Antegrade amnesia is going to be they can't remember the event or they can't load anything in the short-term memory. Retrograde amnesia is they won't remember their name, they won't remember their spouse or their social security number, things like that. Things that they've learned for a very long time. Pupillary response, the 3 S's, size, shape, and symmetry. As intracranial pressure increases, affected pupil tends to dilate and become non-reactive. During a transtentorial herniation and with compression of the third cranial nerve, the pupil has been known to take an oval or a cat eyes appearance. Hippus, constricting and dilating to bright light as the pupil tries to adjust, is an early sign for an uncal hernia. Asymmetrical pupils greater than 1 millimeter are abnormal and an early sign of brainstem herniation. So pupillary responses are very important. Rapid trauma examination. Rapid traumas are done at the point that the patient is not giving us something to focus on. So if the patient is unresponsive, a rapid trauma assessment needs to be performed. It may reveal very subtle clues like skull fractures. Linear skull fracture is the most common, usually a result of low injury, blunt trauma across a broad area of the head. A depressed skull fracture, generally due to a focused high-energy blow of the skull in one location, or a basilar skull fracture, which is the most common. Temporal bone fracture, autouria, leakage of cerebral spinal fluid from the ears, or battle signs, dislocation, discoloration behind the ears that represent hematoma formation. Cranial nerve examination. Extraocular movement. Ask the patient to perform cardinal gazes, move their eyes to the left, right, up, down, have them cross them, see if they can focus. Examine the trigeminal nerve in the forehead. Ask the patient if he can feel his face or forehead being stroked. Tap between the eyebrows. Examine if the forehead wrinkles when the patient smiles. Whispered voice and cerebellar tests. Hearing loss may be indicative of a basilar skull fracture. Cerebral tests can be used to assess an infratemporal mass effect. Assessment. The presence of symptoms complex including Cushing's triad. Now, Cushing's triad is three things, which is hypertension, bradycardia, and altered respiratory pattern. Now, what we'll see with this is things like Shane-Stokes, centroneurogenic hyperventilation, apneutic or ataxic patterns, Biot's respirations, generally progressive. The blood pressure increases to perfuse the brain. Once pressure is assessed at the carotids, an increased parasympathetic tone occurs because they are baroreceptors, and this increases parasympathetic tone or vagal tone and causes the patient to become bradycardic. Now, the one thing that we do not want to do is to give atropine to somebody that has a blood pressure of 200 over 130, heart rate of 40 beats per minute, and has an altered LOC. We want to assess that it might possibly be a head injury. Sit on them, frequent monitoring of vital signs, and take them to the most appropriate location, whether it be a level 1 or isolated neural. For a brain bleed that we are pretty sure that we have a Cushing's triad, we should take them to the level 1 trauma center. So a Glasgow Coma Scale, best indicator of traumatic brain injury, scores between 13 and 15 would be a mild injury. Less than 3% will deteriorate. Scores between 9 and 12 have possible moderate injury, present with altered mental status and or focal neurological defects. 1 in 5 of these patients will deteriorate into coma, although 60% will progress to a good recovery. Scores between 3 and 8 have severe injury. This has a 30% mortality rate. 17% will experience moderate to severe disabilities, and the remainder will be in coma. Treatment. Head injury does not happen alone. 75% have associated multi-systems trauma. Other aspects must not be ignored, and we must treat the patient as a whole. Support their basic functions, things like spinal stabilization, maintain airway control, always do a risk versus benefit assessment, and intubate if necessary. Maintain their PCO2, 35 to 45 millimeters of mercury in normal ranges. Obtain IV access. Maintain adequate blood flow of the brain. This means that the patient must have at least a MAP, or mean arterial pressure, of 60 millimeters of mercury, or a systolic blood pressure of 90 to 100 millimeters of mercury. If they have a seizure, treat them aggressively with the use of diazepam or Versed. Goal-driven therapy. Patients is normal thermic and normal glycemic, normal temperature, and normal blood sugar. Maintain their pulse oximetry between 92 and 100%, and their PaCO2 between 35 and 45 millimeters of mercury. Be sure that they maintain a MAP of 60 and they have a systolic pressure of 90 to 100 millimeters of mercury. As far as evaluation goes, Cushing's triad or cerebral herniation signs treat with therapeutic hyperventilation. Faster, deeper respirations than needed. Does come with some dangers reserved for life-threatening herniation. Hyperosmolar therapies are considered as well, things like mannitol. They've been used to reduce intracranial pressure in the past, but the new information that's coming out, they're not really supported by the Brain Trauma Foundation. Disposition. The patient's survival depends on rapid identification of a hematoma, and a clot extrication via a craniotomy or a craniectomy, or surgical procedures available at the trauma center. So unless they are set up to perform burr holes within the patient's cranial area, or a catch and release, or capture the actual clot that's in there, then you're not doing them any favors by taking them to a hospital that can facilitate their treatment. In conclusion, 50% of death secondary to brain injury occurs within the first 2 hours. The paramedic care is important. Pre-hospital treatment should be focused on the stopping of hypoxia or hypercarbia or high CO2 levels and low blood pressure or hypotension. It helps prevent secondary brain injury, improves overall survival.
If you have any questions concerning this topic, feel free to give me a call. My name is Roy Smith, SmithR@SamaritanEMSOK.com, or 405-492-8243. Thank you.